Rahman Rahim. Dear professors, dear colleagues, it's my pleasure to present this case of a case of syncope in young female. My acknowledgement to Dr. Shaimaa Said and Dr. Yusla Ghazali from Asyut University who prepared the case. Our case is no? Okay. بالضبط. Our lady is 27 years old, neither diabetic, neither hypertensive, had history of palpitation and progressive exertional dyspnea in the last 2 months. Admitted to emergency department with 3 episodes of syncope on exertion in the last 2 weeks. All episodes are preceded by sudden onset of palpitation without family history of sudden cardiac death or syncope. On examination, the pulse was 90 beats per minute with mild irregularity, with normal blood pressure and chest examination, but on heart and cardiac examination, we have pansystolic murmur over the tricuspid area. The ECG, the limb plates showed low amplitude, as we see with the less than 5 millimeter squares. And the chest leads shows two-wave inversion from V1 to V3 and very few infrequent BVCs. On lab investigations, the cardiac enzymes was negative, the normal thyroid function with normal renal and electrolyte was also normal. After initial evaluation for patient with syncope, we have some of high-risk features. First of all, the syncope episode started by sudden onset of palpitation, unexplained systolic murmur, and suspected arrhythmogenic syncope with T-wave inversion from V1 to V3. The patient has 24-hour Holter with frequent polymorphic BVCs, most of them originating from the RV. The BVC's burden was 1,100 BVCs per 24 hour. And this is some of the BVCs. The first lead is lead 2 and V1 and VF and AVF. As we see the left bundle morphology in most of the reported BVCs supporting the RV origin with different origin from the RV. Also here the same, we have frequent BVCs up to bigeminy with RV suspected as the origin for these BVCs. On echocardiography, we have dilated right, the atrium dilated right ventricle with impaired ejection fraction of the left ventricle and moderate tricuspid regurg. This is the apical four-chamber views showing dilated right side, and on the parasternal short axis view, the same is present, dilated right side and impairment of the LV contractility. Again, the four-chamber view shows significant tricuspid regurgitation. So we go for cardiac magnetic resonance to report the abnormalities that has the patient supporting the diagnosis of the RV dysplasia. We have wall motion abnormality in the RV free wall, dilated volumes and impaired ejection fraction of the RV, and the LV shows late gadolinium enhancement in the mid-myocardium and the septal and lateral wall. This view, this apical four-chamber view showing the dilated right side with significant tricuspid regurg was more important, the regional wall motion abnormality in form of akinesia or some part of the basal part of the RV showing this kinetic movement. It maybe could be explained better in the next views with hypertrophied motor band. Also, we notice that the LV contractility is also not so good. Here, on the short axis view, we can notice the wall motion abnormalities in the basal and the outflow segment of the RV, and also the impaired contractility either at the basal level or at the level of the mid cavity of the left ventricle. Again, we can notice the dyskinetic movement of the free wall of the RV. With late gadolinium in phase, we can notice that there are stria band in the mid level of the interventricular septum and also in the lateral wall. We cannot appreciate the presence of these abnormalities in the RV because of the structure, the thin-walled structure of the RV. So we can notice the abnormalities of the late gadolinium enhancement on the RV and the LV better than the right ventricle. And here again, at the two levels of, at the level of the mid cavity, we can notice also the septal stria and also in the lateral wall. And this also on the basal level, we have the same at the septum and the lateral wall. So how can we manage the patient? So we try to confirm our diagnosis and stratify the risk of ventricular arrhythmia and sudden cardiac death, and finally how to prevent both the risk of ventricular arrhythmia and the clinical symptoms of the patient. Thank you.
Thank you, Dr. Ahmed, for the presentation. Now we are ready to listen to Dr. Ahmed Nabil, Professor of Cardiology at Ain Shams University.
Thank you, everybody. Thank you, Dr. Ahmed Farghali, for the invitation. We will talk about syncope in young females and how to diagnose and how to reach a proper diagnosis, because syncope has a wide variability of possibilities. We have many diagnoses, we have many possibilities, many mechanisms. So how can we approach towards a female patient who have syncopal attacks? We all know that syncope is defined as transient loss of consciousness due to cerebral hypoperfusion. And this is characterized by rapid onset and short duration. And it always leaves the case without any neurological sequelae. So there is complete and spontaneous recovery from this syncope without leaving any neurological sequelae. We all know that syncope has a bimodal incidence because it is very frequent in the first era of age between 10 to 25 years, and then the incidence decreases, and then it increases again at the age more than 70 years. So it has bimodal incidence, and it is very frequent at the age range between 10 to 25 years. We all know that there are many conditions that can be incorrectly diagnosed as syncope, but actually it is not a true cardiac syncope or cardiovascular syncope, like psychogenic pseudosyncope, like intracerebral or subarachnoid hemorrhage, like TIAs, whether vertebrobasilar or carotid TIAs, subclavian steal syndrome, many metabolic disorders. All these conditions can mimic or can have the incorrect diagnosis of syncope, but we have to know all the differentiating criteria. Regarding the true syncope or the true transient loss of consciousness, it is either due to reflex syncope or cardiac syncope or due to orthostatic hypotension. And they all share in causing either low cardiac output or low peripheral resistance or both. They all serve as a pathophysiological basis in either two of the mechanisms, either low cardiac output or low peripheral resistance or both. Regarding syncope due to reflex or neurally mediated mechanism, what is very important in young females is the vasovagal, which is very, very common in this age category. Vasovagal either due to orthostatic vasovagal during standing or during emotional stress, like fear, like pain, like instrumentation, even taking blood samples can induce this vasovagal response. Also, it can be due to situational vasovagal syncope or reflex syncope, like after micturition, after swallowing, after coughing or sneezing. This is very common in this age category. Syncope due to orthostatic hypotension in young females, it can be seen mainly in volume depletion. When there is severe loss of fluids like severe hemorrhage, severe diarrhea, severe vomiting, it can cause volume depletion, so it can cause orthostatic hypotension in young females. Maybe the autonomic failure, whether primary or secondary, is not so common in young females. It can be seen more in older age, but the main cause of orthostatic hypotension in young females could be attributed to volume depletion. Regarding cardiac syncope, the most common or the most logic cause is tachycardias, whether it is supraventricular or ventricular tachycardias. It can cause syncope. Also, other structural cardiac disorders like the presence of cardiac tumors like left atrial myxoma, congenital anomalies of coronary arteries, pericardial diseases, and if talking about problems in the cardiopulmonary gate vessels, pulmonary embolism is there in a young female. It can cause, if it is massive pulmonary embolism, it can cause syncope. So, if I have a case of syncope, what is the initial evaluation that I should start with? There are three main items. The first, of course, is careful history taking. Very important to take detailed history about the attack that occurred at the time being, and if there were previous attacks before, very important to take detailed history about what happened. And what is more important is the person who witnessed the attack to see all the circumstances that occurred during the attack. Second is the physical examination. Of course, we should make detailed physical examination, and this examination should include active standing blood pressure test, and we will see it later. And of course, electrocardiogram. The first three items, and based on these findings that we will see, we will proceed for more investigations like continuous ECG monitoring if there is suspicion of arrhythmic syncope, echocardiography, of course, to exclude any structural or cardiac abnormalities, tilt table test if we suspect that the syncope is due to orthostatic hypotension or due to reflex syncope, and some blood tests can be beneficial. If we are suspecting that there is blood loss, we can make hematocrit hemoglobin if there is hemorrhage, oxygen saturation for detecting of hypoxia, D-dimer to exclude pulmonary embolism. What are the criteria in the clinical assessment or the history that can suggest reflex syncope? If I have a syncope after an unpleasant sight or sound or smell or pain, or after an emotional stress, or during meal, or after being in a crowded place or hot places, and if the syncope was preceded by pallor or sweating or prodromal symptoms without known previous cardiac disease, so it is mostly, it is suggestive of being of reflex origin or neurally mediated. While if the syncope came after standing or prolonged standing or postprandial, so it is suggestive that it could be of orthostatic or due to orthostatic hypotension. And this can be confirmed by the active standing test. I measure the blood pressure during sitting, and I stand for 3 minutes, or order the patient to stand here for 3 minutes and measure the blood pressure. If I have a progressive sustained fall on systolic blood pressure more than 20 millimeter mercury, or diastolic blood pressure more than 10 millimeter mercury, or the systolic blood pressure decreased less than 90 millimeter mercury, So this is diagnostic of orthostatic hypotension. And this should be a part in the assessment of any patient with syncopal attacks. Okay, if the syncope comes during exertion, or it is preceded by palpitation, or there is family history of unexplained sudden death at young age, or there is a presence of structural heart disease, so I can suspect a cardiac origin or cardiac cause of syncope. And some ECG criteria can also guide me, like the presence of non-sustained VT. If I found some non-sustained VT in the ECG, if I find a pre-excited QRS complex, long QT interval, short QT interval, early repolarization, signs of Brugada pattern or ST segment elevation in V1, negative T wave inversion in the negative precordial and right precordial leads with the, or if I found an epsilon wave, so it can raise my suspicion that we have an RV dysplasia, LV hypertrophy, maybe in the hypertrophic cardiomyopathy. I can see this finding, so I can suggest or suspect any cardiac cause. Of course, an ECG like this in a patient with syncope, it is definitely a Wolff-Parkinson-White syndrome, so I will go towards the way of EP study and ablation for this patient. A patient with short QT syndrome is susceptible for ventricular arrhythmia and can cause syncope. A patient like this with T wave inversion and relatively tall R wave with maybe a suspicious epsilon wave, so it could be an RV dysplasia. I will send him for more investigations. A patient with Brugada criteria or Brugada pattern, whether type 1 or spontaneous type 1 or induced after tests or in invasive tests. The long QT syndrome with different triggers that can be developed to come torsade de point or to develop torsade de point. All these findings will let me involve the patient in more criteria and more investigations, like even in hospital monitoring. If I have a suspicion of a high risk or life-threatening arrhythmia, I can monitor the patient also with just ambulatory Holter ECG monitoring if the frequency of the symptoms are very frequent. I can use external or implantable loop recorders, but actually they are very costly and they are not available in most of the centers. Smartwatch application, whether it is reliable or not, it is a bit debatable. Echocardiography is very important to exclude any stenotic or severe stenotic lesions or valvular lesions. Structural abnormalities with high probability of arrhythmia can be detected by echo, like Hookham, like RV dysplasia, like dilated myopathy. Cardiac tumors, of course, if I have a left atrial myxoma, it can be detected by echo. Signs of RV strain in massive pulmonary embolism can be detected by echo. And of course, if I have a congenital anomaly causing outflow obstruction, like the presence of subaortic membrane. The tilt-table test is very important because it can diagnose a reflex syncope. If I suspect reflex syncope, but I am not confirming this initial evaluation, it can assess also the autonomic failure in these patients. And very important that it can separate between true reflex syncope and psychogenic or pseudo syncope that can be caused due to psychological causes. Video recording is there, and it is stated in the guidelines in the 2008 in the syncope guidelines in the ESC, and they recommended that the home video recording can be beneficial and can add more information about the situation of the syncope. And if it is added to the tilt-table test, it will be beneficial and will give us more data. Of course, multi-slice CT can be beneficial in some rare conditions, although they are not common, but it can be beneficial in detecting the cause of syncope in young females, like if we have a coronary anomalies or abnormal course of the coronary, and if we have spontaneous coronary dissection, it can be detected by multi-slice CT. Cardiac MRI is very important in detecting, in suspicion of RV dysplasia or dilated myopathy, to detect delayed gadolinium enhancement or to detect areas of fibrosis. Exercise stress test is very important in detecting a special type of patients with catecholaminergic polymorphic VT, in which the ventricular tachycardia comes with exercise. So exercise test can detect this type of patients. And of course, if we suspect any hereditary or channelopathy, we should make genetic testing for all these patients. So to sum up the diagnostic workup in a syncope case, the first assessment is history taking, physical examination, and ECG. These steps will lead us to the next, more deeper investigations, which include echocardiography and ECG monitoring and tilt table test. And more specific investigations may include blood tests, video recording, multi-slice CT, cardiac MRI, stress ECG, and genetic testing in case of hereditary conditions suspected. So in conclusion, syncope in young females share many clinical features with other disorders, and it therefore presents in many differential diagnoses. The principal causes are either reflex or due to orthostatic hypotension or cardiac, whether arrhythmic or structural in origin. Although it is usually attributable to neurally mediated reflex syncope because it is the most common cause of syncope in young females, but there are other differential diagnoses that can be potentially dangerous, and I should detect it cautiously, like cardiac rhythm disturbance, secondary to channelopathies, for example, or due to structural heart disease. So careful history taking, in addition to physical examination, along with clinical correlation, is very important. ECG correlation to discover tachyarrhythmia is very important. It also can discover any structural heart disease or primary electrical disorders that can need more investigations to properly diagnose and risk stratify these patients. Many diagnostic tests are available for proper diagnosis, but what really matters in which test to choose for which patient. Thank you very much.
Thank you, Professor Ahmed Nabil, for this elegant presentation. You covered actually all the potentials in this case, but I have a small question for you. In our case, if the echo was not so evident and was within normal, the also did not show any significant arrhythmia, what would be your first investigation and approach for this patient?
Well, if the echo was normal and the Holter was normal, but I have some suggestive ECG criteria that may raise this suspicion of the RV dysplasia, like the inverted T wave and the tall R wave or the relatively tall R wave in V1. If I am a clever physician, I should suspect the RV dysplasia, or at least put it at least as a possibility. And if I don't find any signs for any cause for RV dysplasia, so I will just raise this suspicion and think of a possibility, maybe it's RV dysplasia. I should search more and more because it's sometimes it is not not all the criteria are apparent in the first stages of the RV dysplasia. Sometimes all these criteria are not present. The epsilon wave is not there. Maybe some RV dilatation can be underestimated by the echocardiographer that makes the echo. So I think it needs some digging in this case.
Would you think of CMR first, or you go for tilt table to exclude common causes like vasovagal first?
Well, actually I can go in both directions.
If the ECG is normal.
Yes, if the ECG is normal,
yes,
I would start with the common. So, as I said in the conclusion, what is common is common. So logically, I will start first. Actually, I will start first with the common causes, the vasovagal, the reflex-mediated syncope. If I find that there is no results or no positive results, I may think of MRI to see if there is a ventricular arrhythmia or caused by an area of fibrosis or RV dysplasia, maybe.
Okay, thank you. Any further questions? Yes.
لو سمحت، في الحالات اللي بنعمل لها كاردياك اكزامينيشن وبتبقى نورمال ونورمال اي سي جي ونورمال ايكو، هل ما نحتاجش ان احنا نعمل نيورو كونسلتيشن في الحالات دي من البدايه؟
ديفينتلي حضرتك.
يعني بدل ما نستنى فترات طويله ونعمل سوفيستيكيتد اكزامينيشن، ففي البدايه نعرض على النيورو كونسلتيشن.
اولا التفكير في النيورو تفكير مظبوط جدا و we should raise the suspicion also in the neurological causes. Sometimes in patients that the history is not fit for true cardiac syncope or true total loss of consciousness, we can make in parallel that we make our investigations and at the same time consult a neurologist for possibility of a neurological cause. Definitely, yes.
شكرا.
Congratulations for your presentation. I enjoyed it enormously. One consideration and one question. You mentioned that watching for a possible cause indicates the diagnosis in the individual patients. But I think that in an educational setting, we should always take into account that whatever diagnosis we estimate to find, there may be an alternative cause that we were not focusing on. In other words, if we think that the patient has hypertrophic cardiomyopathy and we think this is a diagnosis and ventricular arrhythmia is a diagnosis, we should not exclude that reflex syncope or orthostatic syncope may be possible. So never stop your diagnostic process when you think you have identified a possible cause-effect relationship. And the reason being that we now have elements that help us to possibly look for the EKG at the time when recurrence occurs. So that's an additional tool that was not available a few years ago that we tend to use quite frequently in these cases. Now the question relates to the Brugada syndrome. You mentioned type 1 EKG pattern raises a high suspicion of possible ventricular arrhythmias as a cause of syncope in a young female with this condition. And you mentioned type 1, spontaneous type 1 and drug-induced. I think recent data are speaking against the role of drug-induced ST segment elevation in V1, V2 as a possible sign configuring a syndromic condition. And even more, the most recent data in the literature even show that if you have a type 1, you should raise the issue whether this is not a bystander evidence and that Brugada maybe is something that we have overseen. I wanted your opinion about these recent informations.
My knowledge or my information that the appearance of Brugada criteria in provocative tests, like for example Ajmalin, for example, the development of Brugada criteria does not denote or affect by any mean the risk of the patient and the risk certification of the patient. If it is there, so it is there. It has no relation to the risk. It has no relation that the Brugada was not apparent and it appeared by Ajmalin. It does not have a relation or impact on the risk certification. So the presence of Brugada is there, so it is Brugada. Whatever it is spontaneous or it is drug induced, there is no difference. This is my knowledge. If you have any more information, I would be thankful to say. Okay, thank you.
Thank you, Professor Ahmed Nabil. We'll move to the next talk. Caesar type syncope linkage, possibly combined, and how to manage. Okay. We are sorry, Professor Muhammad Hassan apologized. And we move to the next talk. New diagnostic criteria for ARVD by Professor Fatma El-Kafrawi, Professor of Radiology, Aswan Heart Center. Thank you, Dr. Fatma.
Thank you, my professors, for the invitation. It's my pleasure to be here today. Okay, so just the nomenclature about ARVD, it starts at 1982 as a description of developmental defect of the RV myocardium. After that, the term ARVC, or arrhythmogenic right ventricular cardiomyopathy, after discovery of genetic defects in cardiac desmosomes in 1988. Upon that, the task force criteria, the first version 1994, and then modified in 2010. Another term by the Heart Rhythm Society in 2019 was arrhythmogenic heart muscle disease, that not explained by ischemic hypertensive or valvular heart diseases. However, actually this includes a very broad spectrum of diseases, including sarcoidosis, myocarditis, cardiomyopathies, non-desmosomal and desmosomal variants. So making the diagnosis is much more complex. Then another term has been proposed, which is arrhythmogenic cardiomyopathy in 2017 as a consequence of the identification of biventricular and left dominant variants. So the diagnosis of arrhythmogenic cardiomyopathy is challenging due to the lack of single sensitive and specific test. In 1994 task force criteria, there was a qualitative scoring system of familial ECG morphofunctional and structural features, and then modified in 2010 to more quantitative structural and functional criteria, with improvement of the ECG criteria and adding molecular variants. This is the MRI criteria in the modified task force. By MRI, we should have regional RV, dyskinesia, akinesia, or dysynchrony, plus one of the following, either the end diastolic volume index in males more than 110 milli per meter square, or 100 for females, or RV ejection fraction less than 40 to fulfill a major MRI criterion, or if the dyskinesia or akinesia accompanied with a ratio between 100 to 110 in males, or 90 to 100 in females, indexed in diastolic volume, or ejection fraction between 40 to 45. So this is a minor criterion. This is MRI images in 4-chamber and short axis view. Here you can see the dilated RV, the dyskinetic wall with regional aneurysmal formation. Of course, there is dilatation of the tricuspid annulus with regurgitation, and also we can appreciate these findings in the short axis view. However, there are major limitations of the 2010 criteria, either overdiagnosis due to inclusion of molecular genetic variants, misinterpretation of ECG and imaging findings like volumes and regional wall motion abnormality assessment, misdiagnosis of other mimicking diseases, or underdiagnosis due to absence of specific criteria for the LV variants and lack of tissue characterization by late gadolinium enhancement. So regarding the RV volumes in these criteria, actually they depends on the MESA study of 462 healthy controls, and the mean age of these controls was 60 years, which actually is very older than the ARVC group, which usually diagnosed in adolescent or young adults. Then the sequence used by MRI to quantifying the volumes and function, which is the basic gradient or flash sequence. Here, as you can see, there is less resolution or less identification between the blood pool and the myocardium. So this may make inaccuracy in the diagnosis compared to what we have right now in the previous years. This is the CINI SSFP images with much more better resolution and accurate assessment. Another problem that, as we mentioned, they mentioned a specific fixed number, which is 110 or 100 for all age groups. So they just differentiated males or females, and a very large problem comes in athletic population, which there is actually RV remodeling and increased in the end diastolic volumes. So many of these athletes present in the criteria of end diastolic volume enlarged as ARVC. So sometimes, as we said, there is a remodeling, but we will, in the next slices, we will say that we should choose the specific reference numbers for the athletic population if there is a patient who is a competitive athlete. So we shouldn't use the normal reference number, because even the end diastolic volume indexes might reach 120 or 130, which is much more beyond the ARVC criteria. Regarding the regional wall motion abnormality, Of course, it has a very wide inter-observer variability. Sometimes we find regional wall motion abnormality very subtle, but with normal function and volume. So we cannot make any diagnostic criteria by MRI. And sometimes these are of the debatable cases if the patient presented with arrhythmia, but we don't have a fulfilling criteria in MRI. And also there are some pitfalls of non-pathologic RV. Regional wall motion abnormality, actually it's not a wall motion abnormality, it's just a mimicker due to abnormal configuration. So here we can see the tethered RV lateral wall to the sternum by a pericardial band. Sometimes there is the epicolateral bulge distal to the attachment of the end of the moderator band, or butterfly apex, or infectus excavatum with compression on the basal part of the RV and bulging or aneurysmal formation of the RV. However, it will be normally contracting. So all of these are normal variants, but might be interpreted as a regional wall motion abnormality. So what's new in ARVC criteria? So in 2020, this group of Padua criteria have proposed another diagnostic criteria of arrhythmogenic cardiomyopathy. And here we will discuss these new criteria. So the current definition of ARVC is a hereditary heart muscle disease with genetic mutations in cardiac desmosomes, affects young adults, RV, LV, or both. And this is one of the new definitions, because previously it was considered as only an RV disease. The fibrofatty myocardial replacement results in lethal ventricular arrhythmia regardless of the severity of systolic dysfunction. And here you can see by MRI, this is a T1 turbospin echo non-fat SAT. We can see the fat in the lateral wall, and then with fat suppression, we can see the fat is suppressed. However, either in the previous criteria or Padua criteria, the fat or fibrofatty infiltration detection is just a supplementary criteria. It's not a must to have this. And actually, we can find fat in the myocardium within normal population, within obese patients, sometimes old age, or even normally in the RV. So this is just a supportive, but not a must criteria. So the novelty of Padua criteria, they added the tissue characterization by rate gadolinium enhancement for assessment of the myocardial fibrosis in both ventricles, and also new ECG criteria and ventricular arrhythmias specific for the LV involvement. So first, they upgraded the 2010 task force criteria of the RV. So now we have morphofunctional ventricular abnormalities by echo, CMR, or angiography. The major criteria include regional RV akinesia, dyskinesia, or bulging, plus global RV dilatation or systolic dysfunction. However, as I said, it's now should be referred to age and sex body surface area matched reference values. So now we shouldn't depend on a specific number like 100 or 110. Each age group and each sex should be referenced for the reference values, and of course the athletes for the athletic population reference values. And actually the regional wall motion abnormality alone now is considered a minor criterion without any abnormality within the volumes or function. And also the structural myocardial abnormalities, which is the second category, by cardiac MRI, enhanced MRI to detect myocardial fibrosis. So now the transmural late gadolinium enhancement or stria pattern in one or more regions of the RV is considered as a major criterion, and biopsy is limited for very minor indications. Regarding the LV, this is a brand new criteria because there was no criteria in the task force 2010. So the global LV systolic dysfunction with or without dilatation, this is a minor criterion alone. And the regional wall motion criteria of the LV, lateral wall or septum or both, this is also a minor criteria. Again, by MRI, transmural subepicardial or mid-wall LGE in one or more areas of the LV is considered a major criterion, limiting the indications for biopsy. Okay, the role of CMR in Padua criteria. Now, for diagnosis of ARVC or arrhythmogenic cardiomyopathy, at least one RV or LV criterion from morphofunctional or structural categories either major or minor should be fulfilled to make the diagnosis. And the usefulness of tissue characterization in these criteria, it enhances the accuracy of interpretation of regional wall motion abnormality. As I said, regional wall motion is very subjective, but if you suspect some wall motion and at the same time you find a scar in this specific location, so this is abnormal. Also increase the sensitivity for identification of biventricular variants, and contrast enhanced MRI is considered a rule out imaging test right now. Considering the regional wall motion abnormality, LV fat infiltration, and late gadolinium enhancement together, we can reach 98% of accuracy without biopsy. So currently, arrhythmogenic cardiomyopathy is divided into dominant right ventricular variant, which includes the morphofunctional and or structural abnormalities of the RV with no criteria for the LV, or biventricular variants if we have criteria for both ventricles, or dominant left ventricle, which have LV structural abnormality, which means myocardial fibrosis by late gadolinium enhancement, but genetic mutation is a must here, and we will discuss this later. So this is again the classic right-sided variants. It's very similar to the slide we saw in the beginning of the study, and here we can see the lateral wall right ventricular fibrosis without any abnormality of the LV. So this is a right dominant variant. Then the biventricular variants, here you can see the same criteria of the RV, the dilatation, the regional wall motion abnormalities, but here you can see also the LV. There is global systolic dysfunction, there is lateral wall thinning and akinetic areas. So it's like a moth-eaten lateral wall. And at the same time, we have biventricular scar in the whole right lateral wall, and also subepicardial to mid wall in the left ventricle. So this is the biventricular pattern. And as you know, usually the ARVC described with a triangle of dysplasia, which includes the RV inflow, outflow, and apex as specific arrhythmogenic foci. But now, after involvement of the RV of the LV infralateral wall, it's called quadrangle of dysplasia. Then the dominant left variants should include, as we said, structural, mainly fibrosis with or without morphofunctional abnormalities, but genetic mutation is a must because there are many similar factors. Should be no criteria for the RV involvement. The fatty myocardial infiltration might be at the same sites of scar or not. And severe systolic dysfunction here is directly related to the disease progression in the scar, opposite to DCM. So sometimes in the DCM, there is marked disease progression, even if there is no significant scar, but here it's directly related. So the differential diagnosis regarding the RV, any cause of RV dilatation, as we said, athletic remodeling or shunts, like here, sinus venosus ESD or partial anomalous venous return. Another variant or differential diagnosis here, we can see there is abnormal contractility of the RV lateral wall, but also we can appreciate that we cannot see any myocardial tissue at the basal or mid-myocardial level. There is only some trabeculations at the apex with complete scarring of the lateral wall. So this is an example of Olds syndrome. Oh, sorry. Then we have, of course, Epstein anomaly as another variant. The left dominant, as we said, we should include genetics. All of these are 5 different diseases, but they are all similar, having a subepicardial to mid-wall scar. However, here by biopsy, this is ALVC, this is myocarditis, DCM, sarcoidosis, and muscular dystrophy. So we can't diagnose the LV variant only without genetics. So finally, this is the algorithm, but I want to share this only. So this is a study done in 2020 with application of this new Padua criteria. So they had 112 patients, first described with the task force criteria 2010. 87 of them was definite diagnosis of ERVC, 15 borderline, and 9 possible cases. After application of the new criteria, 51 of the 87 diagnosed as biventricular, not right only, and 15 of the borderline was confirmed, 5 confirmed as definite, and 6 confirmed as a biventricular. And the possible cases, from the 9 possible cases, 7 was diagnosed as ALVC. So this is a very huge impact actually in the clinical practice after the application of Padua criteria in practice. I highlighted the MRI part, but actually it has also modifications in the ECG, clinical, genetic, and familial criteria. Thank you so much.
Thank you, Dr. Fatma, for the informative presentation. Can I allow one questions?
Thank you, Dr. Fatma. Very nice and illustrative presentation. I am pediatric cardiology, and I am astonished about this data and why they are focusing on young adult in their criteria. We have arrhythmogenic right ventricle, and but we haven't this left ventricle.
We haven't. So actually, it's the literature usually described as a young adult disease, and they said, I think in the ECG criteria, I have read this before, it's difficult to diagnose the pediatric population, I think.
But we have a lot of arrhythmias.
Yes.
It is not an ECG finding, but we have a lot of arrhythmia in arrhythmogenic right.
We apply the MRI criteria for pediatrics or adults, and this is the importance of using the reference values for the pediatrics. So I use the reference age group for the
and according to the body surface
index,
area
yes.
Or index, and not an absolute value.
Yes, index and for the age of the patient.
And did they involve genomic or the whole exome sequencing in their data, or just?
It's like the Padua criteria. It's the same of the
Padua is the Padova from Italy?
Yeah, from Italy,
yes, okay.
So it's just upgrade of the task force with the 5 items like the ECG, familial, genetics. So it's the same as task force 2010 categories, and they upgraded each one of them. But because I'm a radiologist, so I just highlighted the imaging part. But there is modification of each part of the criteria.
And when you are mentioning major and minor, how we are defining properly, if we have just one measure to define properly this disease, or major and minor?
Okay, so we cannot repeat the criteria. So if I have like wall motion abnormality, I shouldn't consider this as minor. And then some wall motion abnormality with the increase in diastolic volume as another major. So both of them will be one major criteria.
So to define properly, I should have one major criteria. Is it like our criteria? We have a major and minor to some.
يعني هو في الآخر you should have for diagnose like 2 major.
Yes.
2 major and 1 minor. يعني هم لهم classification مش حافظاها، بس قصدي it's not a must all of them from imaging.
Okay.
Even in the previous criteria, MRI was not a must, so we might have criteria in MRI or not. And if we have, usually it's one criteria. But now they said MRI is mandatory, as we said, major or a minor, and presence of a scar alone in the RV is major criteria. Okay. So just if you have MRI and another major ECG or genetic criteria, so you can make the diagnosis.
Very nice presentation. It seems to me that the advent of new diagnostic tools helps physicians to populate the category of previously denominated idiopathic cardiomyopathy. And I think this is a wonderful example, because the accuracy by which findings from the right and the left ventricle through magnetic resonance help to accurately define the morphological characteristic of the underlying cardiomyopathy helps to transition some patients from a previously idiopathic form into an arrhythmogenic form. If we recall, the idiopathic was dilated, which might not be always the case in the population, but it's a characterizing point. The presence of arrhythmias, arrhythmogenic cardiomyopathy is defined by arrhythmia, but idiopathic cardiomyopathies have a risk of arrhythmias. And so I think this is just one of the many categories of underlying substrates in the previous context of idiopathic cardiomyopathy that can be best characterized. And I think we should tribute the group of Padua to jump on this opportunity in such a highly systematic
I
way.
think it will be recently will be added to the task force criteria. There are, in the last like 2 or 3 years after this publication, many literature, as you said, reapplying these criteria on specific entities, and this make different diagnosis. So we think this will be added in as a guidelines or a task force criteria recently.
Thank you very much.
Thank you so much.
Now, I'm happy to welcome Professor Riccardo Capato, the eminent international electrophysiologist from Milan, Italy. He will talk to us about new era for subcutaneous ICD.
Good morning, everybody. I apologize for my voice. I'm not in the best health conditions. And I take the opportunity again to invite the organizing committee to thank them for inviting me to be in this wonderful meeting. I particularly appreciated the generosity and the sense of thankfulness that was expressed in the gala dinner yesterday evening. It really touched my heart. So I was asked to address the issue of subcutaneous ICD therapy in the context of the case report that we had today. And I tried to do this. I also have to say that I have what people might consider an enormous conflict of interest, because I invented the subcutaneous ICD together with Professor Badi in Seattle. So everything I'm telling in favor of the SICD should be addressed with suspicion by each of you. So let's recapitulate the clinical findings, and let's put ourselves back into the case report of today. And I think this is also a way to prepare the discussion that will follow with regards to all the information that we have collected by the distinguished presenters in the various disciplines that are involved in this case. So she is a female. Ahmed, am I correct? 37-year-old. She has palpitation, recurrent syncope, progressive exertional dyspnea, and orthopnea in the last 2 months. And I think this clinical finding, as you correctly addressed before, is particularly important, because if we look at the global context, it is not only the EKG findings, it is not only the echo finding, it's that something happened in her recent history that definitely changed her quality of life. And that should be fixed as an additional criterion to guide our decision process. So a pansystolic murmur is something that you would not expect in a 37-year-old. And in the era where we have all these diagnostic criteria helping us to come to a final decision, thanks to the instrumentation that we use, we should not forget about the power of physical examination. And this would be a wonderful way to teach our younger generations not to forget about it, because unfortunately, they did not grow up at a time when instrumentation was not available. Ventricular bigeminy at baseline 12 EKG is indicative, is informational. And if we look at the polymorphic nature confirmed during 24-hour Holter monitoring, we should know that this is something more than a ventricular ectopy originating from a possibly normal heart. If we have monomorphic ventricular exabeats, we may be compatible with the normal heart. But if we have polymorphic, we should start to suspect that there is something more than a normal heart behind the expression of polymorphism. At echo, dilated right chambers, right atrium, right ventricle is not only right arrhythmogenic right ventricular dysplasia. The right atrium is also involved. Why is that the case? Is that pansystolic murmur possibly responsible for that? It truly appears to be the case because the moderate to severe regurgitation of the tricuspid valve is reported, which supports the objective finding of a pansystolic murmur. Impaired left ventricular function is truly indicative of an underlying myocardial disease. And a small size PFO with insignificant bidirectional shunting tends to eliminate left to right shunting as a possible cause of increased right atrial size. So I would say here the right and the left ventricle are involved, possibly based on a primary disease. The right atrium is involved, possibly as a consequence of tricuspid regurgitation, moderate to severe, and left ventricular impairment is identified, which is indicative of an impact on the prognosis of this young girl. And this is the first diagnosis to me. Biventricular cardiomyopathy with moderate to severe tricuspid regurgitation and polymorphic recurrent ventricular premature beats. I would not speak on differential diagnosis because I think this has been done masterfully by my previous speakers. But I think myocarditis in a young girl should be considered strongly. Further investigation at the time when I received the information, no data on cardiac MRI were available. So I was very pleased to see what the data came out to be in this case. They would provide from a theoretical standpoint indication on the chamber size, which was not available from echocardiographic data, and the presence of and distribution of fibrotic and fatty tissue. But the very point here which calls urgently our attention is this is a young girl with multiple syncopal spells. Are the syncope predictive of a risk of sudden death? This is what our attention should be based on. And also based on the relevant amount of information that we have collected, I think we have to admit that we are falling into a gray zone. There are no clear criteria that indicate the need for sudden death protection. There are not clear data that indicate that this lady can be left home with no further worries. I mentioned the implantable loop recorder because, and you see here with a question mark, because I think this is very important with regards to the possibility to objectivize the EKG findings at the next syncopal episode. We know this lady has a high probability of recurrence. Should we take the privileged opportunity to provide once forever evidence in favor or disfavor of cardiac arrhythmias as a possible cause in this case? It has a highly predictive value in terms of accurate diagnosis. It has a price to pay. If the next episode is the last one, we could regret having implanted an implantable loop recorder under the clinical circumstances that we were considering. And then programmed ventricular stimulation, because if we know that there is a fixed substrate, and if we know about the frequency of ventricular polymorphic premature beats, programmed ventricular stimulation may provide evidence of possible substrates of inducible regular VT or reproducibly inducible ventricular fibrillation at low aggressiveness degree of ventricular stimulation. The presence of regular VT would not only offer a possible explanation for syncopal spells, particularly if hemodynamically non-tolerated in the EP lab, but it would also guide us in the selection of future therapy strategies. Of course, catheter ablation might be a strategy. Say we induce regular ventricular tachycardia, we ablate the arrhythmia. If we are successful and syncopes are gone, we know they were responsible even if we decided not to implant a loop recorder and wait for a next episode to document it. And also to select a transvenous ICD rather than subcutaneous ICDs, because transvenous ICD in this very case would provide the patient with the privilege of anti-tachycardia pacing to terminate the underlying arrhythmia in replacement of an ICD shock that is the only opportunity by subcutaneous ICDs. And finally, this is a very articulated strategy and for diagnosis and therapy for all the reasons that have been discussed in this session. It needs to be explained to the patient in very comprehensible terms. It is complicated for a doctor, let alone for a patient. So once the patient has a clear picture of which guide to select, it should be shared in comprehensible terms with the patient in order for her to understand the clinical scenario and help her in taking a shared decision, particularly important where there are gray zones and we don't know which decisions is the best one. A few words on the SICD. You know, it's entirely subcutaneous in its currently available clinical form. The canister is located in the left hemithorax at the submuscular level, and it's connected through a wire to a lead electrode provided with two sensing electrodes and one defibrillator lead. And the shock is delivered between the central lead and the canister. Data, the strongest data, clinical data, have been provided in Effortless, which is a study, a registry that was started from the first implant of the subcutaneous ICD, and which was conceptualized by Cameron Health, which is the company that Gus and I founded in 2000. Conversion rate of clinical, first of all, 984 patients, age 48 years, ejection fraction 43%. So relatively selected population. Very high conversion rate, 98%. Time to shock, 17 seconds. Remember, this is a 40 joules shock and requires more time to charge the capacitors in order to deliver the energy, but the time was the same at 1 and 5 years. Survival free of complication at 5 years, 84%. Subsequent pacing need 2%. Compatibility with transvenous pacemaker, 100%. Infection, 3.2% overall. And minor complications, in other words, inappropriate shocks, 2.4%. In Praetorian, prospective comparative randomized investigation was made between transvenous and subcutaneous, showing superimposable figures in terms of inappropriate shocks and complications. And most importantly, lead-related complications and device-related complications were significantly higher with the transvenous systems. Now, to complete the presentation, I think it's fair to say that there is a new form of subcutaneous ICD system that is about to be provided on a global basis and accounts on a substernal electrode technology and is referred to as the Global Extravascular ICD Pivotal Study, showing that after 1 year of age, the freedom from major system or procedure-related complications met the Food and Drug Safety, Food and Drug Administration safety criteria fixed at the beginning of the study. And I would stop here to enable some time for discussion if necessary. Thank you very much for your attention. And again, apology for my voice.
Thank you very much,
It's not
Professor
my real
Capetto,
voice.
for this elegant presentation, which was patient-oriented rather than device-oriented. Thank you for that. Any questions?
Thank you, Ricardo. I am a pediatric cardiology again. I have the same scenario, but in asymptomatic patient. 10 years. If we have without syncope and monomorphic, what else I can do?
Clearly, we are in the green zone. We are shifted a little bit more towards white than towards black. That's the only difference. Now, what I generally do in gray zones, I try to be very open-minded, to take the entire clinical scenario into account and every possible considerations, because if I were the parent of this girl, what I would want is a doctor that doesn't know what's going to happen to my daughter, but which tells me what is likely to happen under the circumstances. So I would certainly express the assurance that the probability of this arrhythmia to turn into a life-threatening condition is low. But it's higher than in a little girl of same age without ventricular extra beats. And that we have an option to target this arrhythmia by an electrophysiological investigation, which would help us, number one, to identify the exact origin, number two, to target and remove it when feasible. And in the absence of any cardiomyopathy, the probability of success is in the range between 60 and 80%, which is not trivial. It's not 90% as in many other arrhythmias, but if we don't do anything, it would be zero. And if that arrhythmia has a minimum potential of developing into a life-threatening condition, we will eliminate that risk. And second, if we induce ventricular arrhythmias during the right ventricular stimulation, and we repeatedly do this by low aggressive protocol, we may identify a higher risk to the patient. And with that information in mind, I would leave the decision to the parents.
Because we are very late in time. Thank you very much, Professor Capetto. We will see now how this case was managed in our department. The case wrap-up will be presented by Dr. Ahmed Farghali, please.
Okay, thank you, Mr. Chairperson. So our aim, again, to summarize, to confirm the diagnosis of arrhythmogenic cardiomyopathy, to stratify the risk of ventricular arrhythmia and sudden cardiac death, and to support the patient with therapy that can help her for prevention of sudden cardiac death or improving the symptoms and heart failure symptoms. So how can to reach to diagnosis confirmation? We can follow this chart supported by the team of Professor Croda of Padova University. We can, as we see, we search for one major criteria of RV criteria, and we have actually this criteria. The first criteria of dilated right ventricle with regional wall motion, as we see in the first session. Also, we have the ECG abnormality of T-wave inversion in the right precordial lead. So we can go further in the flow chart and try to check if there is LV involvement or not. And as we see here in the short axis by cardiac magnetic resonance, we have this tria pattern present in the mid myocardium of the left ventricular septum and lateral wall, supporting the diagnosis of biventricular involvement of our patient. So how can we risk stratify the possibility for sudden cardiac death and sudden cardiac arrhythmia and ventricular arrhythmia. The International Task Force risk stratification has present that there are high risk features in form of aborted cardiac arrest or sustained VT or severe LV dysfunction. In our patients, we don't have high risk features. We have only major risk features, which is syncope, and we have moderate LV ejection impairment and RV ejection impairment. Other minor risk features, the younger the age, the cutoff point is not specified. The T-wave inversion with more involvement of the limb lead, of the chest leads, was more increasing the risk, and the also the BVC's inducibility in programmed stimulation. In our patient, the diagnosis for risk stratification we support as class 2 indication for ICD implantation. There are RV risk calculator for sudden cardiac death and ventricular arrhythmia, incorporating many items: age at presentation, the burden of BVCs, and the sex, also the history of arrhythmogenic cardiac syncope, and the morphological features and the ejection fraction by magnetic resonance for the right ventricle, and history of sustained VT. But this risk factor, this calculation has many limitations, as these are lacking the prospective validation. They are based on retrospective observational studies, and also they are studying patients with RV involvement. So there are many limitations. Also, the endpoint was the ventricular arrhythmia, not sudden cardiac death, so there is a little bit overestimation of the risk. So the therapy, how to provide the patient. Unfortunately, our patient lies in the gray zone. So we have we don't have secondary prevention. We have only for primary prevention. But what we have history of syncope and moderate left ventricular and RV ejection fraction. So we go for implantation of transvenous ICD for primary prevention of sudden cardiac death. Therapies to improve the symptoms and to improve the ventricular arrhythmia and ventricular dysfunction. The patient received the beta blockers to improve her symptoms, and also AC inhibitors and diuretics to alleviate the symptoms of dyspnea and progressive exertional dyspnea at the presentation. My take-home messages: the initial, as said by Dr. Ahmed Nabil in the first presentation, the initial clinical evaluation in form of careful history taking and good clinical examination and ECG is very crucial during diagnosis of syncope and management. As Dr. Fatma said, the cardiac magnetic resonance is the gold standard for arrhythmogenic cardiomyopathy diagnosis. Recent studies that shows that most cases have biventricular involvement, with minority of patient has either RV alone or LV alone involvement. Among predictors for serious event, arrhythmogenic syncope and RV and LV dysfunction are considered major risk factors for sudden cardiac death. ICD is effective and safe for prevention of sudden cardiac death, mainly for secondary prevention after aborted cardiac arrest or hemodynamically affected VT, although till now the randomized clinical trials are still lacking. The decision for ICD implantation for primary prevention is more challenging. The use of transvenous system can enable us to pose anti-tachycardia pacing and shock therapy for our patient. Grazie.